Hello, good evening, everyone. And thank you, Maya, for that kind introduction. And I understand this is the penultimate session for the series, and I'd like to take this chance to congratulate Dr. Villanueva and his team for the excellent series of lectures. I was asked to talk about nutrition tonight, and I hope that this lecture can be a good complement to the preceding lecture of Dr. Gueco. But I won't be talking about medical nutrition therapy. Rather, I'd like to think of it as I'll be talking about good nutrition as medical therapy. So I'll be talking about healthy eating patterns in CKD. And I mentioned the dash to the Mediterranean because these are the top two, I would say, top two dietary patterns, healthy dietary patterns that are being promoted for overall health. And when we talk about diet for patients with chronic kidney disease, the tendency is for patients, for example, to ask what not to eat, what to avoid. So directing us to answer in the way of, lowering the salt intake, lowering the phosphorus intake, lowering the meat intake. But maybe we can look at it from a more positive perspective and rather ask or try to answer the question, what can we eat? And this would be a picture of what a typical Mediterranean diet would look like. It's rich in vegetables, legumes, fruits, nuts, cereals, olive oil, and fish, and also a bit of red wine with the meals. So a bit more enticing. And we talk about what we can eat in the guidelines that are there. So for example, the DASH diet for healthy blood pressure, which also emphasizes larger portion with vegetables and fruits. The nutrition guidelines for Filipinos, and then the dietary guidelines for Americans, all along the same line, saying that there should be more fruits and vegetables in the diet. And here I'd like to thank the PSN members who answered that survey. There were about 76 of you who did, and it was phrased, the question was, how Mediterranean is your diet? And there were 9 points there. And those are the 9 points used in the scoring developed by Dr. Checopolo. And you can look at it in this article from the New England Journal of Medicine. And based on that survey, we see here that 6%, only 6% of the membership have a diet that is very Mediterranean, 51% somewhat, and then the rest of that, 43% is not Mediterranean at all. I'm one of those. So we are hardly Mediterranean in our ways with regard to our diet. But that was just based on 9 questions, very general. If you want to do the more comprehensive questionnaire that was used in the study that I'm about to present, and if you have an hour or so to answer that questionnaire, this is the link to that study, the online survey that you can take if you're interested. But the question I'd like to try to answer tonight is this. Among patients with chronic kidney disease, does a healthy dietary pattern reduce the risk of CKD progression and all-cause mortality? And offhand, we would say, of course, the answer is yes. But what evidence do we have out there? And for that, I'd like to present this study. It's a pre-proof. It has not come out officially in a publication, but has already been made available online. And this is the adherence to healthy dietary patterns and risk of CKD progression and all-cause mortality, findings from the CRIC study. So this is a study using the patients enrolled in the chronic renal insufficiency cohort study. And this is by Dr. Emily Hu and the colleagues. And the question we'd like to answer is, among patients with CKD, does a healthy diet reduce the risk of CKD progression and death? But just to make the question a bit more precise, we'll be looking at the association between a healthy diet and a reduction in CKD progression and reduction in death. So the question actually more precisely phrased would be, among patients with CKD, is adherence to a healthy diet associated with a reduced risk of CKD progression and death? So I'll go straight to what the study showed. So the main study features and findings. So in terms of the population, they had 2,403 participants, 21 to 74 years old. So as part of the CRIC study, they had an estimated GFR in the range of 20 to 70 ml per minute per 1.73 meters squared. In terms of the exposure, it was the healthy dietary pattern. They had the participants accomplish that dietary health questionnaire and applied the following dietary scores: the Healthy Eating Index 2015, Alternative Healthy Eating Index 2010, the Alternate Mediterranean Diet Scoring, and the DASH Diet Scoring. But for tonight, I'll just focus on two: the Alternate Mediterranean Diet and the DASH Diet Scoring. The outcome, there were two outcomes of interest: CKD progression, defined as a 50% decline in the eGFR, or kidney transplantation, or starting dialysis. And the other outcome of interest was all-cause mortality. And the methodology used, it was a prospective observational cohort. So it was observational. And they used Cox proportional hazards regression models to estimate hazard ratios, comparing the least adherent to the most adherent group. And what did they find? This is the summary. Among adult CKD patients, followed up for a median of 7 years, divided into tertiles based on their level of adherence to a healthy dietary pattern, the most adherent to a healthy diet had the lowest risk of CKD progression and all-cause mortality. So I'll be doing a critical appraisal. So there are the three elements of the critical appraisal. We look at the validity, the results, and the applicability. And I will say at the start that in terms of validity, ticks off all the yes answers. The study addressed a clearly focused issue. The cohort was recruited in an acceptable way. The exposure was accurately measured to minimize bias. But you'll see that the yes is in lowercase, and I'll explain a bit later why. The outcome was accurately measured to minimize bias. And the authors identified all important confounding factors and accounted for these in the design. And the follow-up of subjects was complete and long enough. Now the results, what are the results? The group with the highest adherence to an alternate Mediterranean diet had a 25% lower risk of CKD progression, a 31% lower risk of death, and a 23% lower risk of the composite outcome. And I would say the results are believable, and I'll explain more later why. Now, can the results be applied to the local population? I would say yes. Do the results of the study fit with other available evidence? Yes, in lowercase. I'll explain why also in the following slides. And I will also be discussing the implications of the study for practice. Now, going through the validity questions, did the study address a clearly focused issue? And clearly the answer would be yes. So this was a study within the CRIC study, which is a prospective observational cohort. And the focus of that study is to focus on major adverse cardiovascular events. So it has a total of 5,000 plus participants. But for this study, it was taken from the phase 1 participants of almost 4,000. In phase 2, they recruited more patients with a higher GFR in the 45 to 70 year range and older. So older with mild to moderate CKD. The primary outcome measure of that study itself was actually the slope of GFR and cardiovascular events. And the secondary outcome measures were onset of end-stage renal disease, CKD progression, the composite of those two, and the slope of change in proteinuria over time. So nested in that, the study, the focus of the study was very, very clear. The healthy dietary pattern, what happens to primary outcomes. Okay, now the next question would be, was the cohort recruited in an acceptable way? The answer also is yes. So the inclusion was the CRIC, but who were excluded? The following patients were excluded: if they did not fill out the questionnaire, if they had an extreme energy intake by self-report, meaning less than 500 to 700 calories per day, extremely low, or more than 3,500 to 4,500 calories per day, extremely high. Or if there was insufficient data to calculate the dietary scores, or there were missing covariates of interest. And from that, 1,500 were excluded. So we have our 2,400 patients in the study. Now, just to look at the characteristics of the excluded versus the included subjects. The excluded subjects, there were more patients among them who had cardiovascular disease, who had hypertension, diabetes, were smokers, and were male. So those were excluded. So we would say that the ones included were the healthier population. So being healthier, it's actually harder to show the impact of a healthy dietary pattern on lowering CKD progression and death. And that's what the investigators had to deal with. Now let's look at the dietary profile of the included subjects based on the Mediterranean diet. And you see here, these are their characteristics. In the lowest tertile versus the highest tertile, or the far from Mediterranean to the very Mediterranean dietary pattern. Their total energy intake was at 1.7 to 1.9. Protein intake was higher in the highest tertile group, 82 grams. But they did not give any data about gram per kilogram per day. It wasn't available in the manuscript. Sodium was also on the high side, 3.2 grams, 2.5 in the lowest tertile. Potassium, 3.6 grams versus 2.5. Phosphorus, 1.3 versus 1.0. And they had data about FGF23. And interestingly, even if the phosphorus intake was higher in the highest tertile, the FGF23 level was lower. But that wasn't discussed too much in the manuscript. And in the acid load, the lowest tertile had an acid load of positive 0.2. And the highest tertile, which is very Mediterranean, so high in fruits and vegetables, had a negative 8 acid load. Okay. So the next question, was the exposure accurately measured to minimize bias? So the food frequency questionnaire for this study was self-reported. And that's the main weakness of this study, also acknowledged by the investigators themselves. Is, for example, you did the survey, the 9 questions, and you answered in a certain way. But then the question arises, is what you say you eat the same as what you actually eat? So there will be measurement error there in terms of recall, or maybe in terms of also response bias. You will tend to give a response that will be appealing to, well, the investigator, but not necessarily the investigator, even to yourself. What will sound nicer to you as a response? So I drink more than, less than 1 glass of beer a day. 2 sometimes, but yeah, I'll say less than 1, that sort of thing. Now, let's say you answered it accurately. What you say you eat is what you actually eat. But then the next question is your dietary pattern consistent over a long period of observation? And the investigators accounted for this, actually. What they did was to conduct the food frequency questionnaire at baseline, then at year 2, then at year 4, and use a cumulative average approach to come up with their data. And then the next question is, are these dietary scores applicable to people with CKD? So the dietary scores used are widely used in the general population, but the question arises, are they really applicable to the CKD progression, CKD population? So this weakness was also acknowledged by the investigators. So it's yes with a lowercase. Next is, was the outcome accurately measured to minimize bias? And here the answer is easily yes, because the outcomes of interest are objective, straightforward, and not subject to interpretation. 50% decline in GFR, you just calculate. Kidney transplant or dialysis and all-cause mortality, they can look at the national registries, and that's what they actually did. Now the next question, have the authors identified all important confounding factors, and have they taken account of these in the design? And this would be the main, I think, stumbling block, because this is a prospective study and it is observational in nature. So we're trying to look at the association between the healthy diet and the reduction in CKD progression and death. But when we look at CKD progression and death, we have to clarify that these are actually competing risks, because when a patient dies, then they can no longer demonstrate CKD progression. So we can draw the diagram this way. So with a healthy diet, does that reduce the incidence of death? And does that reduce CKD progression? So that association, we don't know. So if we assume that there is a null association between the treatment and the outcome, then if there are other factors that are associated with both the exposure, the diet, and the outcome of death and CKD progression, then that can create a false association. So we look at the risk factors. The risk factors for death in the CKD population would include older age, male sex, obesity, smoking, alcohol intake, being sedentary, having diabetes, hypertension, cardiovascular disease, and a low HDL. In terms of CKD progression, the risk factors should be the same, and particularly add to that with the low GFR in the first place, higher rate of proteinuria, not being on RAS blockers. So those risk factors lead to these outcomes. But the thing is, they can be associated with the diet itself. So if you have a poor diet, that can lead to diabetes and hypertension. But then if a patient finds out that they have diabetes, maybe they will work harder on a better diet. So there is a relationship between risk factor and diet. So because the risk factors are associated with both the outcome and the exposure, then they are confounders. So that can confound the association between the two, even if healthy diet and death and progression per se were not associated. So what the investigators did was to adjust for those risk factors, and that was planned. But then there's another thing, well, in terms of the risk factors, you see here some are in red and some are in blue. And that's because when I look at the comparison between the lowest tertile and the highest tertile had an older population, 60 versus 56. So that will work against the association. Alcohol intake, 28 versus 21, higher. Low HDL, 50 versus 48, higher. So that works against the association. But then there were also less smokers in the highest tertile, 5% versus 19%. And that's blue because it will be favorable. And then the low GFR, the GFR in the highest tertile was 49 versus 45. So that's also favorable to that. And the proteinuria was also lower, 0.7 gram per day versus 1.1. That's favorable. So you have a mix of favorable and not favorable associations here. But the investigators adjusted for those. The other thing to consider is that there may be mediators. So maybe healthy diet is not directly associated with CKD progression, but it's actually mediated by other factors. So in this case, for example, the C-reactive protein, there's more inflammation that is induced by an unhealthy diet. FGF23, because it's very high in phosphorus and additives, lower bicarbonate and higher BUN, and uric acid because of the high meat intake and the high purine intake. And so maybe it's the mediator, the high CRP, FGF23, etc., that leads to the progression rather than the healthy diet, the unhealthy diet per se. So what the investigators did was to plan a mediator analysis in the sensitivity analysis. The last thing that the investigators planned was for reverse causation, meaning if a patient finds out that they have CKD progression, then maybe that will compel them or inspire them to work on their diet. So the CKD progression will cause a change in the dietary pattern of the patient rather than the other way. So it will be a case of reverse causation. So what the investigators did was to plan for that ahead, and they will do sensitivity analysis excluding patients with CKD progression events within a shorter period of time, within 2 years. So it seems like they covered a lot of things in terms of confounders in their planned analysis. So next, and the last question for validity, was the follow-up of subjects complete and long enough? And the answer is yes. It's a longer follow-up time than previous studies, and the investigators were particularly proud of this, that they had a median follow-up of 7 years with a range of 3 to 14 years. And there was rigorous follow-up done to ascertain the CKD progression using the visit data and linking it to the National Registry for end-stage renal disease. So it seems that the methodology is valid, and so we can look at the results. So what are the results and how precise are the results? So the first, how many primary outcome occurrences did they note? So this was 2,400 patients. There were 855 cases of CKD progression and 773 deaths. So 35.6% CKD progression, 26.9% end-stage renal disease, and 32.2% deaths. So it's a very high-risk population, and there were a lot of events to look at. So what did the results show? Among the most adherent to the diet, to the alternate Mediterranean diet, there was a 25% reduction in CKD progression, a 31% reduction in all-cause mortality, a 23% reduction in the composite outcome of the two. Among those most adherent to the DASH diet, there was a 17% reduction in CKD progression, 25% reduction in all-cause mortality, and 17% reduction in the composite outcome. So quite impressive. If we look at it graphically, you see here in the three tertiles. So tertile 1 would be the one set to a hazard ratio of 1, and tertile 2 and tertile 3 were compared to that. So tertile 1 is the least adherent, tertile 2 is sort of adherent, and then tertile 3 is the maximally adherent to the Mediterranean diet. And you see here that the hazard ratio is really much lower for the tertile 3. And you see the same thing with the DASH diet. But the other thing is that the alternate Mediterranean diet has a more impressive picture. Now, just a comment here about the participants with a high dietary score. The investigators noted that they were more likely to be female, be a college graduate, have a higher income level, and be a current drinker. And also that they have diabetes, a higher eGFR, a lower urinary protein, higher HDL cholesterol, more likely not to smoke, and more likely not to have hypertension. So this seems to be the profile of those who are highly adherent to one of the four healthy dietary patterns that were discussed there. So I think many of us in the society can relate to this profile. Okay, so next question is, do you believe the results? And I would say yes, based on these 4 points. First, exposure preceded outcome, of course, because this is a prospective cohort study. So the exposure was there, and then the outcomes were followed over time. But the other things is that there's a dose response region, there is consistency, and there's biological possibility. So the dose response region, you can see here in terms of the tertiles, tertile 1, 2, 3, in terms of CKD progression, all-cause mortality, and the composite, there is a steady decline as you become more adherent to the diet. And this is for the alternate Mediterranean diet. And this is for the DASH diet, and you see the same pattern. So there's the dose response gradient demonstrated, and there's also consistency. And back to the mediation analysis, maybe it has to do with the CRP, FGF23, the bicarb, the BU, and the uric acid. But what they did in the modeling here shown is that if you put in those mediators, there's hardly any movement in the association. It was not affected. And the last thing was about the reverse causation. So maybe CKD progression caused a change in diet, but what they showed was that the associations persisted even when participants with a CKD progression event within 2 years of follow-up were excluded. Okay, now the last point is in terms of biological plausibility. So if you have lower meat intake, a high fruit and vegetable diet, then there will be a less dietary load. And with a less dietary load, then there will be less renal injury. And some of those points were already raised by Dr. Gueco in her lecture earlier. And just to add to that, you have less elevation of the ammonium concentration, that was discussed, less complement activation and oxidative stress, that was also shown in the graph earlier, less endothelin-1 production, and also less aldosterone production. And further point is that you will have more healthy microbiota diversity. With that kind of diet, there will be more fiber and lower fat intake, and that would lead to higher levels of short-chain fatty acids that you see when there are a lot of microbiota. And the other side of the coin of the microbiota diversity is that there will be less dysbiosis. So there will be less uremic toxins that are being generated, like trimethylamine N oxide, indoxyl sulfate, and precresyl sulfate. So there is biological plausibility to the association. Now, they also did the post-hoc analysis in terms of the 9 components of the Mediterranean diet. And you see here, the red line is the hazard ratio of 1. And interestingly, it was the nuts that were shown to have the best in terms of reduction in hazard of CKD progression and death. Number 2 would be vegetables. So just a word about the nuts in terms of the biological plausibility. Nuts are, well, a rich source of magnesium that helps prevent endothelial dysfunction and inflammation. It's also a rich source of protein, and it's a plant protein, and plant proteins are associated with lower FGF23 and higher bicarb levels, leading to better kidney function. And nuts are also a rich sourse of phytate. And phytate apparently has an impact in terms of lowering intestinal phosphorus absorption. And nuts also are a rich source of high fiber and polyphenol content, leading to that microbiota diversity, and also a rich source of unsaturated fatty acids. So that's just the thing about nuts. Nuts have a lot of bad press among Filipinos, and apparently peanuts are related to gout. And well, this came out from the Philippine Rheumatology Association, making the point that peanuts actually do not lead to gout, and peanuts are actually effective in helping to prevent gout. But looking at that in terms of a causal diagram thing, what came about there? Nuts can actually reduce the serum uric acid level. And so nuts would theoretically reduce the incidence of gout. But in the Filipino mind, nuts lead to gout, and I think it's because of a certain confounder, and that confounder is beer. That those who are eating the nuts are drinking the beer, and if we have to blame something and stop something, maybe it's easier to stop eating the nuts rather than drinking the beer. But if we want to prove that there is no association between nuts and gout, then we'd have to do a study where we control for beer and maybe look at the relation between nuts and gout among those who are non-beer drinkers to show that there is actually no association. Okay, now this graph just shows the result of the survey that we did for PSN members, the 9 components. So you have here the red bar will be those who are far from Mediterranean in their diet. So I'm one of those. And the blue bar would be those who have a very Mediterranean diet. So in terms of vegetable intake, we're good. We're not good. So more of us are far from Mediterranean than Mediterranean. We only passed in 3 categories: fruits, grains, and fish intake. Legumes, very far, nuts also. So I guess if we have to work on our own diet, these are the things that we can look up to improve. Okay. Now the next question is, can the results be applied to the local population? And I look at the study composition. It's actually half were non-white. But the non-white population had mostly Black and Hispanic. There was no mention of Asians being included in the PRIC study. I'm not sure how many Asians were there. But, well, I asked this question: what McDonald's is in the US? One picture of McDonald's is in the US and one is in the Philippines. And if I ask you which one is in the Philippines, can you identify which McDonald's is in the Philippines? Well, I'll run a poll here, but we can ask. I can check the chat later. Which your guess is. But just to make the point that I think the number of McDonald's here is illustrative of the, well, maybe the idea that the diet here and the diet in the US is actually very, very similar. Okay. So do the results of this study fit with other available evidence? And I would say the answer is yes. This is a 7-country study, and this is Ansel Keys, who was key in looking at that, the relation between diet and coronary disease. And one of the things that came out in that 7-country study is elevating the status of the Mediterranean style diet as being particularly healthy. And so this study would corroborate that and look at the CKD population in particular. But the 7-country study did not look at the CKD population in particular. So these are studies that did. So this one by Banerjee et al. Looked at the DASH dietary pattern and showed that there's poor accordance to the DASH dietary pattern. The poor accordance to the DASH dietary pattern is associated with a higher risk of ESRD among adults with moderate chronic kidney disease and hypertension. So that corroborates the finding of this cohort study. And also this other one, a meta-analysis of cohort studies. This one showed, the answer is yes and no. Yes, it showed that there is a reduction in mortality among patients with a healthy dietary pattern. But in terms of end-stage renal disease, there seems to be no association. There seems to be no impact. So it's a mixed answer of yes and no. So it would be a yes with a lower case, would be the final answer. So what are the implications of this study for practice? So Dr. Gueca already mentioned the KDOQI guidelines that came out in 2020. And if we look at what it had to say about the Mediterranean diet, it says in adults with CKD 1 to 5 not on dialysis or post-transplantation, with or without dyslipidemia, we suggest prescribing a Mediterranean diet to maybe improve lipid profiles. And then in terms of fruits and vegetables, in adults with CKD 1 to 4, we suggest prescribing increased fruit and vegetable intake to decrease, because it may decrease body weight, blood pressure, and net acid production. Okay. So what we have to clarify here is that, well, if this study came out, because it came out, it's still to come out in publication, but it came out online just in the last few months. If it came out, would it be included in the KDOQI guidelines? Well, the KDOQI actually for intervention studies would have excluded observational studies. So this is an observational cohort. We would have to corroborate these findings in the randomized controlled trial or a clinical trial before it would have more weight. But as it is, actually, I think it does give good evidence, but the remaining question is if there is residual confounding that we haven't accounted for. That if we account for these residual confounding, they might eliminate the association between the dietary pattern and CKD progression and death. So that question remains. Nevertheless, I think we should continue with the advice that we'd give in terms of the main message, as shown here in the CKD Nutrition Manual of Dr. Marlin and her team. And shout out to Dr. Marlin and her team for producing this nutrition manual. And you see here in the plate that is recommended, more vegetables. Vegetables is half the plate, and then grains, and then 1/4 is protein. And I think the only thing that we can maybe revisit in terms of the manual is maybe including the nuts in the mix. And this is even better. The team is not done. It's working on the Filipino translation. And I think after the Tagalog translation, there might be work later on in terms of even more dialects in our country. So that's something to look forward to. And maybe this is something that we can do on a daily basis. We did that survey, but maybe this can be used as a daily intake report card on our part. How many of the vegetables, legumes, fruits, nuts, grains, and fish did we consume, and did we limit our intake of alcohol and red processed meat? So in summary, and in answer, I would say this is the conclusion, that among patients with chronic kidney disease, adherence to dietary patterns such as the Mediterranean or the DASH diet is associated with a reduced risk of CKD progression and all-cause mortality. And that's the end of my slide. Thank you very much.
Thank you, Dr. Tanchanco. That was a very enlightening and interesting discussion on the DASH and Mediterranean diets. Diet is actually the most frequently asked topic by CKD patients in our clinics. I'm sure you will agree. We appreciate the fact that you highlighted the study showing the benefit of adhering to healthy diets and slowing the progression of CKD. Thank you, sir. We are now ready to entertain questions. There's one question from Dr. Estrella. Do we have a checklist to identify risks and red flags in the periodic assessment of our patients' nutrition?
Risks and red flags. I would say it has to do with we look at the overall progression of our patients, and there are things that we are supposed to check at certain intervals. So in terms of of course, the GFR and the proteinuria, but in terms of nutrition, we're looking at let's say the calcium, the phosphorus, the vitamin D, all of those things. And I think in terms of red flags would be, it's not the value per se, but the overall trend that we see. So maybe it's not hitting that, it hasn't breached the levels yet, but you see the pattern. The trend is not looking good. So if the trend is really clear already, then maybe that's already time to intervene in terms of revisiting what's going on. How's the patient doing? How's the attempt to adhere to the diet? What's blocking them from adhering? What's the overall situation? So I think looking at the overall trend is something to look at even before you breach the values going into the red zone.
Sir, I have a question, sir.
Yeah.
You showed some of the Mediterranean diet appears to be better than the DASH, right? According to the studies that you showed. However, this diet recommends, I think, 7 to 10 servings per day of fruits and vegetables, from what I remember. So this can also mean more potassium in the diet. So how can we reconcile this with a recommendation to limit dietary potassium, especially in patients with advanced CKD or patients who are on RAS inhibitors?
Yeah. So, well, just to clarify first what they did in terms of the scoring. So the scoring they did was, they based it on the previous study and looked at the median score. And then the median score was what was used as a basis for assessing whether it was a pass or a fail in terms of that Mediterranean diet. So that's the thing. The score itself was developed in a general population, and then it was applied to this CKD population because there were no other instruments out there. So I guess that's a cautionary note there in terms of what was done in terms of the scoring. So the potassium intake, yeah, generally fruits and vegetables, you will have a higher intake of potassium. But I think also the caution is there. I think Dr. Gueco mentioned the danger of low sodium diet in all patients. And high potassium is definitely not good, but high sodium is definitely not good, but low sodium might also not be so good. I would say the same thing for potassium. So we don't want too high of potassium, but it has to be higher than usual because we tend to be not high in our potassium intake. Because a low potassium intake is also not good. It can actually also accelerate CKD injury. So we're looking for that fine, I guess we're walking a tightrope, looking at that fine balance. Yeah.
Are there more questions from the audience? Sir.
Yeah.
Yeah. All right, Russell. Before we sign off, we'd like to announce the first research forum on Sunday, September 6th from 9 to 11 a.m. This is open to both fellows in training and all consultants, especially those who are part of the research committee. We'd also like to invite you to our last web lecture. Next Wednesday, the speaker will be Dr. Edgar Lerma. And that's it for tonight. Thank you very much for your attention and participation. Good night, everyone, and stay safe.